finish with insult this half morning before lunch.
Morning session.
Morning session.
On the program title is Moyamoya disease in children. But the initial Moyamoya disease was described in children's as a children's disease, but further experience shows that it is as high incidence as in adults, and similar, same as in children in earlier age. So I combined. I don't have much of the pediatric cases. Mostly what we experience was adult cases. So we're going to basically go over what the Moyamoya disease is, and I'll show you some cases of complex anatomical angiographic features. Moyamoya disease is first described in 1957. Our Japanese colleague must know better than I do. It was the first described as a hyperplasia of the bilateral internal carotid artery. It was published in Japanese society like a booklet or the bulletin. It was in 1957, and Japanese shinkai means is a nerve. Is that correct?
Yeah.
Okay, this was published in 1957, and later it was later published in the Western Journal 1969. In 1969 it was called as Moyamoya disease, and first described in 1975 in Western journals. What Moyamoya means, like smoke comes off the chimney, okay? And like is the Moyamoya in Korean is morak, similar description of this pattern. What it is these because of the deep collaterals developed and major arteries and carotid artery closes, it shows like some dense small vessel network. That's what was described as it was. Original description of the Moyamoya disease is idiopathic, progressive, stenosis or occlusion of the distal internal carotid artery and or A1 or M1 segments with the development of small vessel collaterals at the base of the brain, PL surface or lepton meninges. External carotid 2 PL arterial collateral can develop. It is supposed to be bilateral involvement. It is classical Moyamoya disease description. In later stage, posterior cerebral artery or basilar artery can be involved. There's no associated disease was first description. This is such a case. As you can see, patient presented a little hemorrhage in the thalamus, but CTA showed more of dilated vessels along the convexity, and selective angiogram shows you can see almost complete occlusion of the internal A1 segment. The severe stenosis M1 contralateral side demonstrates you can see complete occlusion with a minimum filling of the collaterals, and then you can see superficial temporal artery is giving collateral transcranial to dural to PL collaterals. This is typical classification of the Moyamoya disease. This is another example. You can see bilateral involvement. The left internal carotid artery is completely occluded. There's extensive collaterals, deep collaterals from the posterior circulation to the thalamus and basal ganglia region, and right side shows severe stenosis and complete occlusion at distal A1 segment. And distal M2 branches are filling through the deep collaterals and lenticular artery and collaterals and reconstituting portion of middle cerebral artery branches. these are more typical angiographic features of moyamoya disease. So pathologically, this was well described by Michael Scott of Boston Children's Hospital. He published this review article in New England Journal of Medicine, I think it was 2009, in which he showed, I took pictures from that publication. You can see there's a thickening of the intima and fibrocellular thickening of the intima and hyperplasia of the endothelium. And you can see the internal elastic lamina shows indwelling, undulating appearance, and interestingly, thinning of the media. Muscle layers are thinned. That's one of the findings you see in moyamoya vessels. Contrary to moyamoya disease, moyamoya syndrome, pathological appearance is a similar, angiographic features of the similar. However, those conditions are associated with other diseases such as autoimmune disease, neurofibromatosis 1, sickle cell Down syndrome, or post-radiation changes can cause similar occlusion and deep collaterals. However, those usually are unilateral lesions, so that's why in case you have associated disease, we call it the moyamoya syndrome, not moyamoya disease. This is one of those cases which has only unilateral involvement of this internal choroidal changes. Contralateral shows completely normal appearance. And this is another example of normal contralateral internal choroidal artery, but ipsilateral shows deep collaterals and occlusion of the M1 branch on this specific case. This is an interesting case. This is actually not Asian. This is American. The case I did in Boston. This patient had a severe stenosis of the distal internal choroidal artery, as you can see here. And however, proximal portion of the internal choroidal artery also shows a severe arteriosclerotic changes. Even though the similar pattern as moyamoya, this is secondary to arteriosclerotic disease rather than typical moyamoya disease, what we described before. Definition has been changed from the initial description to more present diagnostic criteria. Japan has established in 1978 the Research Committee on Moyamoya Disease, and they created the initial diagnostic criteria for 1987, revised in 1995, 2009, 15, and 2000. More recently, 2021, they revised the diagnostic criteria of moyamoya disease. And it's worthwhile to review 2009 criteria, and we will review 2000, more recent 2021. Before errors of MRI or CTA, the diagnosis was mainly made by the selective angiograms. However, the improvement of the imaging quality of the MRI as well as the CT, MRI diagnosis was included. Even though you don't have selective angiogram, you consider that moyamoya disease, it fits the criteria of MRI imaging qualities. Certainly, we'll go over stenosis of occlusion of the terminal internal choroidal artery A1 or M1, abnormal vascular network and venicity of the occluded segment. If these findings are shown in MRI, it's also MRI or MRA, they considered as a classical diagnosis of moyamoya disease. Pathology is the same, thickening of the intima, causing luminal narrowing, and waviness of internal elastic lamina and thinning of the media. In 2009, and changes has to be bilateral to call moyamoya disease. Okay? And there's no associated disease such as we described autoimmune disease or such a things. That's a little bit changed. So over the years, we found some of the cases, unilateral involvement case, may extend to involve contralateral side as well. Okay? Michael Scott reported that 40% of the unilateral cases has no associated disease progresses to become bilateral lesions. Even unilateral changes can be diagnosed if this RNF213 mutation gene is found. This is a more recent discovery. 2011 reported RNF213 gene is associated with moyamoya disease. So in case this is positive and unilateral involvement, they call it as a moyamoya disease. And on MRI, decreased outer diameter of involved arteries bilateral on the heavy T2 weighted images is one criteria of diagnosis on MRA. There's no arteriosclerotic changes. Arteriosclerotic changes, you have more thickening of muscle wall or enhancement of the vessel wall. So those are clearly differentiated on MRA with vessel wall images and such other extensive MR images. And moyamoya syndrome, they eliminated secondary head trauma or secondary hypothyroidism or secondary arteriosclerotic disease. They excluded as moyamoya syndrome. So those are more of more recent diagnostic criteria of moyamoya disease and moyamoya syndrome. Let me show you a few examples. This patient had a minimum symptoms and underwent this MRI, and MRI showed that this is dilated small vessels at the basal ganglion region, and the reconstructed image shows clearly occlusion of the one side M1 and severe stenosis of the A1 segment, and you can see the changes going on in middle cerebral artery and on contralateral side with the deep collaterals. This is sufficient for diagnosis of the moyamoya disease. Some of the CTA findings, they did not include CTA, but we've been seeing CTA cases such as this case. Patient, his mother was diagnosed of moyamoya disease, and so he was completely normal, no symptoms, and he underwent a CTA rather than MRA, and this was the findings. You can see these deep collaterals demonstrated well on CTA. Reconstructed image shows complete occlusion of the bilateral M1 segments. It's clearly illustrate moyamoya disease. And certainly more recently we tried to see more of a vessel wall images, and I don't have complete data, but when we diagnose moyamoya, suspect moyamoya disease, we go through the vessel wall imagings. This is, you can certainly see the complete occlusion of the distal M1 segment. This was actually showing some of that deep collaterals and surface collaterals, and we also gave enhancement, contrast enhancement to see whether there is any changes similar to arteriosclerosis, not moyamoya disease, to rule out any other possible associated diseases. We do use the vessel wall images. This is again one example of the vessel wall. You can see the deep collaterals at the base of the, especially the left side. There's a minimum enhancement of the vessel wall. I mean the main trunk of that vessel involved, and there's a minimum enhancement, but we don't see extensive enhancement like a plaque, or you can see in vessel wall images. Okay. And moyamoya disease in Japan, there's incidence is 3 out of 100,000. Okay. In Korea, it's 1.6 to 2.3. This is national report, but this is I don't know. It's similar. Incidence is about as similar as in Japan and Korea. in my, looking over the statistics of national health insurance. Compare those, Europe is 0.3, about 1/10 of the incidence. United States is similar. Okay? Those patients which is more Asian origin or blacks are higher incidence of myocardial disease compared to white or Hispanics. Females are more involved. Okay? Peak age is about 10 to 20 reported in Japan, but Korea reports 5 to 14 years in children, and in adult, and 45 to 54 years of second peak. So first peak is when child is 5 to 10 years old, and second peak is adult, 40 to 50 years old. There's certainly second peak of the myocardial disease incidences. Okay? And about 10 to 15% of all cases of myocardial disease, patient has a family history, and one family member diagnosis as a myocardial disease, and there is about 30 to 40% of 40 times of chance one family member will get myocardial disease. And I mentioned about RNF123 mutation. That's seen in 95% of infamilial cases, and 75% of the sporadic cases we observe. So RNF213 gene is important diagnostic tool for the myocardial disease. And if you look at the collaterals certainly it can be intracerebral, it can be PL network, or it can be leptomeningeal and dural and scalp vessels also can give collaterals to PL vessels. Let's go over a few of the examples. So this is one case which illustrates this is the base of the skull, the base of the brain collateral. You can see the occlusion of the M1 segment, and lenticular striate arteries are dilated at the typical pattern of moya. And you will see the reconstitution of the distal branches through this deep collaterals. And also anterior choroidal artery is giving also the collaterals to the PL vessels. Okay? And later you may see the filling of the PL vessels through this deep collaterals. Intracerebral, so-called medullary artery collaterals. Okay? This is an example of the deep collaterals coming from the posterior cerebral artery, and one of those has an aneurysm, as you can see, because of the weakness and dilatation of the small vessels, it's easy to form the aneurysm, such as this case. The same case, you have the superficial temporal artery giving through the emissary foramen and filling the dural branch, and then filling the anterior cerebral artery territory, as you can see here. And there's a gain ophthalmic artery to ethmoidal artery, and giving this area base of the brain, certainly gyrus rectus area is filling through this collaterals, and sometimes you may see the occipital artery is giving collateral to the posterior cerebral artery as well. And I try to illustrate some of the examples of the collaterals can occur. And also, this is one of those collaterals which can happen through this corpus callosum. You can see this through the corpus callosum. When I was a fellow, one of my teachers showed the small perforating arteries going through the corpus callosum, they connecting each other. That can be collateral, and you can see the later filling. And this is a pericallosal artery branch is filling in the later stage through this deep collaterals of the corpus callosum. Okay? This is again, and showing the collaterals going through the deep corpus callosum collaterals. One of the things interesting about this myocardial disease is some of the vessels may not involve. You can see M2 branch is involved, but one of the inferior division branch is not involved at all. Because the inferior division is not involved, and so all the distal PL network is also forming. This is one of the collateral to occluded P2 segment, the M2 segment. And another example of the artery of Humeral is also contributing to collateral development of that as well. To see the prognosis of the disease, they made this a Suzuki grading system. Suzuki grading system was, kind of features, angiographic features of this. But it's difficult to differentiate some of the cases. But usually 1 and 2, stage 1 and 2, at this stage is minimum changes. Patients usually have very little symptoms. But it progresses to 3rd, 4th, they may have more symptomatic. And final stage, 5 and 6 stages, you may have a total occlusion and patient become more symptomatic or ischemic lesions. This is examples of this Suzuki grade 1 and 2. The minimum collateral development, the stenosis, not complete occlusion yet, but stenotic lesions. This is one of those patients who presented with chronic headache. You can see there's no complete occlusion there, but severe stenosis developed because the collateral is through deep collaterals are developing. PL network is also developing on this left side, this elective angiogram. Okay? This is a little bit further advanced stage 2, I believe. You can see stenosis of the supraclavian segment of the internal carotid artery and branches of the anterior and middle cerebral artery as well. And another example of the stage 2 or stage 3 levels, you can see here this way. Stage 3 is a progressive ICA stenosis with intensification of Moyamoya-associated collaterals, development of the ECA collateral, middle cerebral, the middle meningeal artery or superficial temporal artery giving collaterals. This is one of the examples you can see. More deeper collaterals are developing. Leptomeningeal collateral is extensive and bilaterally. And another example, you can see these deep collaterals are intensified from the posterior cerebral artery, and you can see the anterior cerebral artery. The deep lenticular striate artery collateral is developing. You can see the corpus callosum area is also developing collaterals, and then each patient had a middle cerebral artery, maybe the middle meningeal artery collateral to the contralateral anterior cerebral artery territory is filling this way. You can see that extensive filling of the anterior cerebral artery, and there's a leptomeningeal collateral coming from the posterior cerebral artery to anterior cerebral artery territory. This is a patient who presented with a TIA initially, and it progressed to this more intensifying the collaterals and progressively narrowing and occlusion of the M1 segment on the left side, as we can see, and this is a specific case. Grade 5 and 6 is more of the distal stages. As more prognosis of progression of the intimal hyperplasia happens, and luminal narrowing happens, and the more complete occlusion happens. And so, as collateral decreases according to these descriptions. And this is a patient, certainly on the left side, I do believe is a stage 6, and compared to right side. And this patient did progress. This was 2019 MRA, and you can see 2021 from the 19 to 2021 in 2-year period. You can see from the stage 4 or 5 progressed to complete the 6 bilateral occlusion and decrease reduction of the collateral circulations this way. And this patient again, this the known case you seen earlier, patient presented with hemorrhage initially, and when we had an angiogram a few years later, you can see there's complete occlusion of the internal carotid artery and very little collateral at the base of the brain as well. Okay? This is contralateral side showing some collateral patient middle cerebral artery, some deeper collaterals seen here. Okay? This patient had a 5-year follow-up, which shows progression of the stenosis, occlusion of the internal carotid artery on the left side. This is another patient who had 2 episodes of weakness, and he has a history of loss of consciousness about when he was 17 years old. And when we did follow the study, you can see the complete occlusion of the right internal carotid artery. Superficial temporal artery is giving collateral to the anterior cerebral artery territory. Left anterior cerebral artery is completely occluded. The left internal carotid artery is completely occluded. As you can see, there's a collateral coming from the falx or cerebral artery going through the anterior cerebral artery territory. Right? So these are the to judge prognosis of the individual disease, individual patients. The Suzuki classification was made by the group in Japan. Okay? Clinical presentations usually present with a TIA or ischemic stroke, and sometimes intracerebral hemorrhage or subarachnoid hemorrhage can occur, seizure or headache or incidental. Some of the cases are found incidentally. And children has more ischemic strokes, and adult has more hemorrhage. 20% of the adult cases are presented with hemorrhage, but 2.8% in children's cases present as hemorrhages. So this, remember, children tend to have more stroke, adult has more hemorrhages. And pediatrics, ischemic symptoms are 70 to 80%. 40% is just a TIAs, but 40% certainly shows infarct. Okay? And there's ischemic symptoms are precipitated or aggravated by crying, coughing, or hyperventilation. Okay? So especially if this patient with Moyamoya disease, you try to don't make them cry, so make it until you have a further treatment. Try to keep child calm. And symptoms of headache or seizure can occur. Intracerebral hemorrhage is certainly less than adult population, and progressively declining cognitive functions. There's more than half of the population in children's Moyamoya disease patients go through the cognitive decline over the years. And this is to show you some of the cases are totally asymptomatic, even though far advanced angiographic features. This patient is a male, 54 years old, totally asymptomatic, and he went through the routine physical examination and found this pattern of angiographic features of the Moyamoya disease. And this patient had routine physical examination, no symptoms. And in Korea, the national health insurance covers every 2 years 1 CT scan for free. So patient usually goes to the CT, and during the CT exam, he was found to have complete occlusion of middle cerebral artery bilaterally and with the collateral circulations. And this is confusion studies. This is a patient presented with transient left side weakness. The MRI certainly showed that there's a small dot of the stroke, but angiographic feature is more extensive than what you expect to see on the MRI examination. This patient did have a left side weakness, but he had a further advanced the angiographic features. You can see quite extensive changes what we have here. This is one of the interesting cases. Patient had this TIA and small infarct and kind of transitional zone of the anterior and middle cerebral artery transition zone. But this progressed to further. This is actually, you can see the August 29th, he was in the hospital and discharged, and he came back with this more extensive stroke, and angiographic features about the same, but it seems like he had some episode of hypertension, whatever, and he had to develop a more extensive stroke. This is another patient with a multiple small stroke, but this is progressed to complete the stroke of the middle cerebral artery territory, and they had to do these craniectomy to survive it, but eventually progressed. You can see in the bilateral massive stroke and eventually died. The patient died of this. This is a patient presented with intracerebral hemorrhage. This is insular and lateral basal ganglia area. You have extensive hemorrhage, and you can certainly see the evidence of stenosis and collaterals on the MRI, the CTA. And fortunately, they went in and they evacuated hematoma, and he survived. But after the recovery, the angiogram certainly shows the typical appearance of a Moyamoya pattern on the ruptured point. This patient did have intracerebral hemorrhage, but extended hematoma extended to the intraventricular space, so deficit was not that severe. However, secondary to this progression of the disease, patient developed dementia and progressive cognitive function. Some of the hemorrhages are totally intraventricular. You can see this case has intraventricular hemorrhage with a little stroke. Other than that, very minimum symptoms. Angiographic features are very advanced stage, especially on the right side. And this patient did have a huge hemorrhage, and this is the only case we see exact point of the hemorrhage. This is, you can see the pseudoaneurysm of the deep branch of the lenticular artery. You can see the pseudoaneurysm developed. This was ruptured and caused extensive hemorrhage like this. This is it's rare to see the subarachnoid hemorrhage and Moyamoya disease, but some of the patients do develop subarachnoid hemorrhage. This is I think the only case I see the subarachnoid hemorrhage. This is, you can see the central surface, and there's a little blood in the central surface, but I do believe some of this PL network has ruptured and caused the subarachnoid hemorrhage. Some unfortunate case, this patient developed this thalamic hemorrhage, and certainly the CTA pattern shows suggestive of Moyamoya disease, and then eventually extended, didn't survive at all. Okay. Last comment on Moyamoya disease, I still have a question. Why some patient had bilateral involvement, some patient had only serious unilateral, very minor changes on the opposite side? We still don't know. Okay? And there's also cases has a spontaneous occlusion, and especially in Korea, I see a lot of this spontaneous occlusion without any serious deep collaterals, and just a leptomeningeal collateral, very minimum changes. Let me show you a couple of cases. This is a patient who presented with no serious, this is a routine exam, shows complete M1 occlusion. There's no collaterals. All rely on leptomeningeal collaterals. This is another patient who has some ischemic event, but nothing serious. This patient, just a little bit of the the infarct in basal ganglia. But you can see there's no collateral, just the lateral collateral are reliable. Another case. So we try to do now is correlate to whether this patient do have the INF213 gene mutation or not. Okay? Some patients do have it, some patients, about more than half patients do not have this gene mutation. And just occlusion of the M1 without any obvious. Most of the patients totally asymptomatic. So I don't know why. I barely seen in the United States, but in the last 5 years I've seen a lot of this spontaneous M1 occlusion without any collaterals. Is it the same disease? I don't know. So Moyamoya disease is a mysterious disease and causes are idiopathic. And we are seeing more of a gene origin disease, but still we are learning of this disease. Thank you.